So we're going to talk about discharge teaching. Discharge teaching, the most important thing is self-care. It is the key. Self-care is the art and science of helping patients understand their illness, cope with their medical regimen, and prevent relapse by recognizing if and when problems occur. This kind of teaching, self-care, allows the patients to take charge of their illness and become partners in the treatment process. Self-care also includes the family. It starts with pre-discharge planning, which positively influences the social and community adjustment variables, deals with satisfaction and stress levels, and compliance with the medication regimens and follow-up appointments. Recidivism is basically relapse. It's the ultimate failure of self-care teaching. Readmission rates for mental health patients are extremely high and they continue to rise. Effective teaching methods can help decrease inpatient readmissions, and inpatient readmissions occur because the patient and family are unable to cope with a crisis in an outpatient setting. So although you've done the teaching, if something happens, they're not prepared for what happens, and they panic basically, and they don't deal well with those crises moments, and they end up with relapse. Okay, some of the factors that are related to relapse are not initiating treatment as soon as the signs and symptoms worsen. This only works if the patient and or the family are knowledgeable about the illness and about what those signs and symptoms are of worsening conditions. It takes a great deal of teaching on the nurse's part, and it takes a great deal of understanding and patience on the patient and family's part both. Support groups understand the conditions, and so they're able to give support on the outside. Support groups are vital to preventing relapses, and they reinforce the teachings that the nurses give to the patients. So before you ever discharge a patient, you have to know what those community resources are available for them, and you have to get them connected with those support groups and those people on the outside that can help them, and their families as well. Sometimes it's going to be a group effort as far as the whole family going to a support group. Sometimes it's just family, and then sometimes it's just the patient. So you have to give those patients the options of what's out there available to them, and that's one of the reasons that community resources is so important to you, especially with mental health patients. Family knowledge and support also. It's easier for the family to return the patient to the hospital rather than to cope with the illness, especially in a crisis moment. The patient suffers then because of the stigma associated with rehospitalization. And it's not just a stigma from the family. It's a stigma from the community itself and the friends and everyone that's around that is involved with this, that even indirectly, because everyone knows that when this person disappears, why they've disappeared. They also are not very good at handling crisis sometimes, and handling crisis is essential for the patient and for the family. And if not the patient, the family has to be the one to give this person what they need. They have to know how to handle stress, and how they handle stress is indicative of how they'll handle a recurring illness. If the family and the patient themselves can't handle stress, and that's one of the reasons they've gotten to this point for whatever reason, then they're not going to be very good at managing this illness. They have to have something that helps them with stress relief as well. They have to have some kind of knowledge about what their triggers are, and to avoid them. Medication compliance is another one. The patients and the families have to know about the medications. They have to know what the proper dosages are. They have to know what the potential therapeutic and adverse side effects are. They have to know what the schedule is. They have to know what they can or cannot take with this medication. They have to know if there are any parameters associated with this medication. They cannot just be told these things. They have to have handouts. They have to have the literature in their hands, have to have something to refer to so that they are compliant. They have to understand that if this medication is to be taken 3 times a day, that it has to be taken 3 times a day, and it has to be taken on a certain schedule. Those things have to be stressed to them over and over and over again. And like I said, you have to give them the paperwork, the literature in front of them to reinforce that to them on a regular basis as well. So all of those things together are the reasons that patients relapse, the factors that are help them prevent from being having a relapse, the support groups and such. Okay, understanding the diagnosis. First of all, psych terms are confusing to patients and to their families. They consider it a label that they've had put on them. They need to know what the diagnosis means in very specific lay terms. They need to know how to cope with the symptoms. They have to know what the symptoms are first so that they can cope with them. And then you have to teach them the implications of the psychosocial and the biochemical aspects of their diagnosis. They have to be able to you have to be able to completely explain to the patient and the family in concrete physiologic terms what it is. And if they understand what it is in those very basic concrete terms, then they're more likely to be compliant with their medication and their treatment regimen. Not just the medication, but the treatment regimen if they're supposed to go to counseling, or if they need these support groups, or whatever the case is, whatever the rest of their treatment is besides the medication. They have to understand this, and you have to explain it to them in very basic concrete terms. You have to be able to explain the basic concepts of neurotransmitters and how psych illnesses can affect how the neurotransmitters work. You have to be able to explain with pictures and with diagrams, and you have to be able to explain how the particular drugs act on those synapses and how it causes symptomology changes. So whatever it is, if they're visual, draw them pictures. If they're not, talk to them in terms. Demonstrate. Find something that they can connect with to understand how this diagnosis affects the neurotransmitters, and then how these drugs act on the synapses to decrease the symptomology, and what happens when they do not take these medications and the symptoms return. So they have to be able to connect the two. It's like little puzzle pieces to them that they have to be able to fit together to understand it. Many psych patients have some knowledge of common illnesses like diabetes, and they can easily relate biochemical imbalances to blood sugar imbalances. They have to understand that mental health diagnoses are cyclical and recur. Just because they take the medication and they're better 1 minute doesn't mean that they're never going to have symptoms again. That they may go through, especially bipolar, and you have those manic and those depressive phases or something. They have to understand that they are cyclical and that they do recur. To help them understand that illness, you may be related to the seasons and how the seasons change, and how to more effectively institute preventive measures. Again, with the triggers, if there's something that triggers them to have a manic episode or to have a depressive episode, or whatever the case may be, help them understand that. Put it in those concrete terms and say, if you do this, or you put yourself in this situation, that this is what happens. Even with medication cannot always prevent a relapse or a stress or an event. Again, dealing with the stressors and learning to avoid the stressors if possible. Psych patients also need to understand that they cannot be cured, that they have to cope with the illness, that there is no cure, and no matter what they do, they will never be cured. That is just a coping mechanism that they use to deal with this illness. The outcome measures then become not the absence of symptoms for them, but how well the patient will cope with the symptoms that do occur. So for them, again, it's not an absence of symptoms because it is cyclical, but it's how those patients deal with those symptoms when they do occur. The families tend to be guilty, feel guilty, and feel responsible. So you have to have discussions with the family about their guilt and their concerns. They have to understand that it's not their fault unless for some reason they're just not being involved in this and they're not helping this person, not helping recognize when when there are stressors and when the symptoms have changed and their triggers are there. You have to teach the family the signs and symptoms also, so again, so they can intervene when the symptoms worsen, and if the patient is failing to recognize it or fails to admit it. Sometimes the patient does recognize but doesn't want the consequences of admitting it because maybe they have to be hospitalized, maybe they have to take more medication, maybe they have to do more therapy. Whatever is involved with it, those patients have to understand that. You have to teach the patient and their family that they are a team, that they must work together, and that the therapist is their coach. Bibliotherapy are basically books for lay people to understand. Articles from journals and periodicals and pharmaceutical companies or pamphlets, anything that there is that are in lay terms that helps them with the understanding of the diagnosis itself, of the symptoms, of triggers of the symptoms, the medication, whatever you can to put in their hands, their hot little hands, so that they understand. So bibliotherapy is what that is. You have to also help them lessen the stigma. You have to have positive focus, and you have to emphasize the commonality of problems that exist. There has to be homework for both the patient and the family. They have to read before appointments. Not before, between appointments. And then at the next appointment, clarify any misconceptions. Ask them for return demonstrations. What are the signs and symptoms? How is this person going to act? What happens if they don't take their medication? You have to have feedback from them, and then you need to clarify for them the misconceptions that they have. So it's going to be homework for them to do between appointments, and then you're clarifying and you're asking for that return feedback when they come back to the next appointment. And also sometimes people are more apt to have positive thinking about this if they know that there are famous people that also have the same mental illness that they do, and you have to demonstrate to them how those people have been able to cope with their illness. So if you can, whatever their diagnosis is, find someone famous. If they are interested in music, find somebody in the musical world that they admire, that they are aware of, that has this illness also. If they're into clothes, into fashion, find somebody in the modeling industry. Find some kind of designer, something. Find someone that is famous in whatever they like, and tell them about that person and how this person has dealt with their illness, and let them know that they can go on, that there are coping mechanisms, that they can still do what they want to do, but they just have to be cognizant of what is going on with them so that they can prevent these relapses and recognize these symptoms and these stressors when they occur. Okay, let's talk about the stressors. Discovery of the stressors is the first and most important thing. You can't fix it if you don't know what it is. So you have a history of events that lead up to the crisis. The patient and the family both have to be aware of when the crisis is, and the first time they may not be. But in subsequent episodes, they have to be aware of what's going on and what happened that led up to this crisis. The patient always tends to look for external causes, many times that are not there. Other times it's clear. It's childbirth, it's a new job, a change in marital status, death of a family or a friend, something to do with a pet, something to do with a child. There's always something that's a trigger. And so they think it's something internally, and more times than not, it's going to be an external trigger. Teach prevention. Okay, you may not always be able to prevent a relapse, but you may be able to lessen the severity of it. So as the patient becomes more and more familiar with what the triggers are and what the stressors are and the things that cause issues for them, They may be able later on to avoid it. In the beginning, probably not, but you'll be able to teach them to lessen the severity of the crisis. They're taught to be tuned in to those stressors. If they go through a great deal of if they have a great deal of unavoidable stress in one area, then they need to eliminate stress in other areas. Um, there are changes in the signs and symptoms then as to whether they're coping or not. So again, if